Okay. So, good afternoon, everyone. Today we are here going to discuss most expected questions for our upcoming FMG exam. So, rather than wasting any sort of time, let's
Okay.
start
So,
with discussion. Good
good
afternoon,
afternoon,
everyone.
everyone.
Today we
Today
are
we are
here
here
going to
going to
discuss
discuss
most
most
expected
expected
questions
questions
for
for
our
our
upcoming
upcoming
FMG
FMG
exam.
exam.
So
So,
rather
rather
than
than
wasting
wasting
any
any
sort
sort
of
of
time,
time,
let's
let's
start
start
with
with discussion.
discussion.
Just a minute.
Good
Good
afternoon,
afternoon,
everyone.
everyone.
Today we
Today we
are
are
here
here
going
going
to
to
our
our
upcoming
upcoming
FMG
FMG
exam.
exam.
So
So,
rather
rather
than
than
wasting
wasting
any
any
sort
sort
of
of
time,
time,
let's
let's
start.
so
ઓકે એમાં જો ને અવાજ આવે છે બ્લૂટૂથ ભરાઈ જાય. Okay, so let's start with discussion of the questions. Starting with the first question. So only survivor in Ahmedabad plane crash. Only survivor of Ahmedabad plane crash 1 month ago. So in this clinical question, we have been given a question that is time duration is 1 month. Time duration is 1 month and is suffering from various symptoms like decrease in concentration, insomnia, flashbacks, and distressing dreams. So, what are the symptoms being given over here? So, symptoms like decrease in concentration, patient is feeling insomnic in his part, he is having flashbacks and he is having distressing dreams. So now you very well know a patient is likely to be suffering from which of the following disorder. So looking to the clinical question, you very well know that patient have went into severe, patient has gone under severe trauma like condition, and out of this particular part if patient is have underwent severe trauma, and then there can be two diagnoses, either there can be adjustment disorder or PTSD. You very well know algophobia is not, it is nothing but it is pain, related to pain something. And the fourth option that has been given is generalized anxiety disorder, and you very well know in generalized anxiety disorder, you very well know that in this disorder patient will be having severe anxiety and patient will be having of anxious nature. Yes or no? Right? So do you agree with me on this particular part? So now let's differentiate between PTSD and post traumatic stress disorder. So you very well know that we have been saying from the very beginning, how can we differentiate PTSD and adjustment disorder? How can we differentiate between PTSD and adjustment disorder? That is only we can differentiate on the basis of time duration. We very well know that we can differentiate on the basis of time duration. So you very well know the time duration in our clinical question is been given 1 month. So you very well know from the very beginning I have already explained, if it is PTSD beta, if it is PTSD, time duration should be, if it is PTSD, the time duration should be more than 1 month. And if similar sort of symptoms are given, but if they are the time duration, if the time duration has been given, if the time duration has been given, if it is given less than 1 month, less than 1 month, then it has to be an adjustment disorder. So looking to the clinical question and everything, if we have discussed the current answer is PTSD. What is PTSD? Post traumatic stress disorder. And I have already explained, I have given a mnemonic for PTSD, that is MAHI. What is MAHI? And I have given a mnemonic for PTSD, that is MAHI. What is M for? What is M for? Mood and cognitive symptoms. Mood and cognitive symptoms, negative thoughts will be there. What is A for? Patient will be become hyper arousal. So A is for arousal. Yes or no? H is for, what is H is for? A is for avoidance, H is for hyper arousal. Yes or no? A is for avoidance. A is for avoidance. A is for avoidance. And I, you very well know, I is for intrusion symptoms. What are intrusion symptoms, my dear? Intrusion symptoms are nothing but it is distressing dreams and flashback. Yes or no? So looking to the clinical question, the first thing which comes in our mind, looking to the duration of the clinical question, it is PT, as this is the most expected question for this exam. PTSD will be there in the clinical question. Now coming to the second part, now let's look to the second part. Which of the following are the features of Korsakoff psychosis? And now from the clinical question, you can easily make out if the question comes about Korsakoff psychosis or Wernicke's encephalopathy, you very well know they are patient is chronic alcoholic. If patient is chronic alcoholic, then and then only it goes in thus in such terms. Yes or no? So looking to the clinical question, let's talk about Korsakoff psychosis. But looking before to the question, I want to discuss you two differences between Korsakoff psychosis and Wernicke's encephalopathy. So just for now, let me discuss this two to three symptoms about Wernicke's encephalopathy and Korsakoff psychosis. And you very well know both of this disorder is due to decrease, deficiency of thiamine. Yes or no? If it is due to decrease in thiamine deficiency, that means. But what is the difference between Wernicke's encephalopathy? Is thiamine reversible? It is due to thiamine reversible. But if I talk about Korsakoff psychosis, it is due to thiamine. It is thiamine irreversible disorder. And you very well know global mnemonic what we have for Wernicke's encephalopathy is Goa. Where what we go by what the reason we go for Goa? To enjoy, to drink. Yes or no? After going to Goa, what are the symptoms? What patient is having for Wernicke's encephalopathy? It is for global confusion. O for ophthalmoplegia. O for ophthalmoplegia, and A is for ataxia. Okay, now if I talk about Korsakoff, we very well know we have majorly discussed one of a symptom, that is confabulation. That is nothing but it is confabulation. Yes or no? Now look to the question. Let's come to the Korsakoff psychosis question. Which of the following features are Korsakoff psychosis? Are features of Korsakoff psychosis? First one is amnesia. Second one is confabulation. Third one is ophthalmoplegia. And fourth one is polyneuropathy. So what do you think? So what are the symptoms of Korsakoff psychosis? Can you expect patient of Korsakoff psychosis to have amnesia? Yes, patient will be having amnesia. Then what about confabulation? Yes, I have already discussed confabulation is seen in Korsakoff psychosis. So confabulation is also a feature of Korsakoff psychosis. What about ophthalmoplegia? Ophthalmoplegia is rarely seen in Korsakoff psychosis. Ophthalmoplegia is more commonly associated with Wernicke's encephalopathy. So we are right now giving you a question over here, and next one, that is polyneuropathy. Polyneuropathy is commonly seen with Korsakoff psychosis, more commonly seen with Korsakoff psychosis. You very well know that peripheral neuropathy is you very well know it is consequences of B1 deficiency, and this deficiency is seen in Korsakoff psychosis. So yes, so there are three symptoms related to this. What are the features of Korsakoff psychosis? Is first one is amnesia, second one is confabulation, and third one is polyneuropathy. So let's go to the options. What are the options given over here? You very well know ophthalmoplegia is not a feature of Korsakoff psychosis. So see over here, there are three options in which C is given. So we can easily rule out these are not three options. What we are looking for A, B, and D. What is A over here for? Amnesia. What is B over here for? Confabulation. And what is D over here for? That is polyneuropathy. So this is the second MCQ. What we are looking for, which of the following is not a feature of Korsakoff psychosis? That is amnesia. Which of the following features of Korsakoff psychosis? First one is amnesia, confabulation, polyneuropathy. Now coming to the third question. A child with a normal IQ and learning for his age is weak in mathematics reasoning. So very well know the question is more probably going to SLD. What is SLD, beta? It is specific learning disorder. It is specific learning disorder. So a child with a normal IQ and learning skill for his age is weak in mathematics reasoning. So if a child is having difficulty in math, you very well know we call it as dyscalculia. We call it as what, beta? Dyscalculia. Yes or no? But if a child is having difficulty in reading, then what we call it as? We call it as dyslexia. And what if a child is having difficulty in writing? If a child is having difficulty in writing, we call it as what? Dysgraphia. Yes or no? So these are the three symptoms which are more commonly associated with specific learning disorder. Despite being tutored by a private tutor for 1 year, the child showed no improvement. What is the most likely diagnosis? So you very well know the currently options, whatever the options given about, first one is ADHD, second one is autism spectrum disorder, the third one is Asperger's syndrome, and third one is specific learning disorder. Out of this four question, you very well know surely it is not ADHD. What is ADHD? ADHD is attention deficit hyperactivity disorder. So there will be other symptoms that child cannot sit, he cannot wait for his class, and attention deficit child will not be able to pay proper concentration whatever been taught in the class or wherever he is, right? So fidgets with hands, there are various symptoms of ADHD. So surely it is not an ADHD. Autism spectrum disorder, you very well know what is autism. Child will be having difficulty in communication, not able to speak properly in, I mean, in communication ways. Yes or no? He will very difficulty to for rearranging everything, whatever things are present at particular place. Autistic child or autistic person will need in a particular place. It is very difficult for him to adjust. So that is specifically, yes, it is not an autism spectrum disorder. And then if I talk about Asperger's syndrome, it is rarely been asked, which is not associated with sort of symptoms. So the only option which we have is specific learning disorder, and the correct answer is specific learning disorder. Is most commonly seen in child with dyscalculia, dyslexia. It is not dyslexia, it is dyslexia. It is L, and whatever it is writing, it is dysgraphia. Am I clear with this thing? Then coming to the next question, beta. A child having difficulty in assessment, he had an IQ of 55. So in the clinical question, it has been given that child is having a IQ 55. So I want you to make this very this is one of the most expected question in our exam. This is the most expected question what we are having this time, that if a student is having an IQ of 55, according to DSM-5, what is the what he should fall into the following category. So you very well know IQ. We have differentiated if a child is suffering from any sort of IQ disorder. We have been differentiated into various part. Yes or no? In what sort of part we have been differentiated? That is mild, moderate, severe, and profound. So my question is, how can we differentiate if it is child is having IQ of 55? Yes or no? If a child is having IQ 55, so let's draw a table and then we can differentiate either the child is the mildly disabled, moderately disabled, or it is severe disabled, or it is profound disabled. So let's make a table how we can differentiate. So this, we make a table for a mental retardation child. So if when a child has been mentally retarded, we have, as I said, we have differentiated 4 parts. First one is mild, then we called it as moderate, then we called it as severe, and then we called it as what, beta? Then we called it as, it is a profound intellectual disability. So very well, let's we start with the mild. If it is child is mild, IQ will fall into 50 to 69. If a child is having moderate disability, it will fall moderate, it is 35 to 49. If it is severe, it will be falling into 20 to 34. And if a child is having less than 20, then the child is called to be profoundly mentally retarded. So look to the clinical question. What does clinical question states? A child is an IQ of 55. A child is having IQ of 55. So according to DSM-5, if it is 55, beta, it falls under the category of mild. It falls under the category of mild. So here the question is, so answer is child is mild intellectual disabled. Am I clear with this question? Sure. Done with this thing. So let's move to the next question. Now, a 30-year-old woman was brought to the psychiatric OPD by her friend. The patient claims that her boss is in love with her and stalks with her. So now, yes, the woman's friend refuses her claims. What is your diagnosis? So reading to the clinical question, see, I always want everyone to read the clinical question perfectly. Whatever the question is given, read the 4 options and then go to answer. So looking to the current question, it is going along with the set of delusions. Yes or no? Currently, patient is having what? Patient feels that her boss is in love with him. So whenever a patient feels that someone of higher stature is in love with him or her, yes or no, when a patient feels that someone of higher stature, some person of a higher stature is in love with him or her, of course, she's talking about the boss, of course boss will be having of higher stature. Yes or no? So what this delusion is, anyone, what this delusion is called to be? This delusion is called to be delusion of love. So what is delusion of love over here? It is delusion of love. So delusion of love is also called to be. Of course, in the clinical question, not going to give delusion of love. What they are going to give? Another name of delusion of love. So another name of delusion love are nothing but it is erotomania. And even if it is not erotomania is given, then it may be given like what it can be given. It can be given like D. Celembrol's syndrome. So what are the options you can see over here? There are 4 options. Megalomania, so no, we haven't heard about any word sort of for our particular well-being, that is megalomania. No. Delusion of reference, what is delusion of reference? When some people are talking about them, then we call it as delusion of reference. Delusion of control, no, of course it is erotomania. So this is for the 5th question. A 30-year-old woman was brought to the psychiatric OPD by her friend. Patient claims that her boss is in love with her and stalks her. Woman's friend refuses the claims. What is the diagnosis? So your answer will be erotomania. When patient feels that someone of higher stature is in love with him or her, at that particular point we call it is delusion of love or erotomania or D. Celembrol's syndrome. So of course in the clinical question, if it is not given delusion of love, it can be erotomania or D. Celembrol's syndrome. So looking to the clinical question presently given over here is erotomania. So there will be one MCQ from delusion. So now coming to the some pharma point of view, a chronic smoker wants to quit smoking. Which of the following will help him with his goal? So there are 4 options given over here, and out of that 3 are given with the drugs, that is bupropion, mirtazapine and varenicline. You very well know it has been repeatedly asked in NEET PG and FMG, which are the drugs what we use to quit smoking. The first one is bupropion and second one is varenicline. But I have already explained, if look to the 4th option. What is the option 4th given? It is both A and C. Whenever they are given both A and C, then you should mark both A and C. Yes, but when the 4th option is not as both A and C and any another drug is given, so you will take the better option. You very well know which is better in smoking. Anyone? Which is better in smoking? That is varenicline is far better than bupropion. But why do we not use varenicline in day-to-day practical life? Because varenicline have a major side effect of suicidal thoughts. Varenicline have a side effect as a suicidal thought. So in a day-to-day practice, if they are asking, then it will be bupropion. Am I clear with this thing? Sure? Okay. Come to the next question. A specimen. The specimen in the below image was obtained from a woman's stomach, which specialized Which specialist is recommended alongside a surgeon in this clinical question, in this clinical case? You very well know this is a image based question from surgery point of view along with the psychiatric point of view. A child person is having maybe a child or maybe any person. This is more commonly associated with females, and you very well know this is the clinical case of Trichobezoar, and you very well know in Trichobezoar a patient is having any a feeling to eat hairs. When they pluck out their hair, they feel good relief, and some people do may eat. And when they get a tuft of hair, when they get a tuft of hair in the stomach, it will be changing its shape, and it will take a shape of our heart. So you very well know, along with the surgeon, yes, we need to remove this case. So of course, the surgeon will be the most important person in clinical in this treating the patient, and along with that, we need a psychiatrist to treat the patient. So I'm not going to discuss about neurologist, cardio and dermo. Basically in this clinical question, you very well know two people treat this patient. First one is psychiatrist and second one is surgeon. So this is the case of Trichobezoar. This is one of an image based question. We are expecting this question in our exam this time. Am I clear with this thing? Okay. This one was much easy. Coming to the next question. A 9-year-old child has a has a mental age of 3 years, has found an IQ, has found an IQ 3 years has found from IQ test. What category of intellectual disability does this child belong to? So you very well know that they are asking about mental retardation. Yes or no? In what sort of category does patient fall in? So you very well know two ages are given, mental age and chronicle age. Yes or no? If you want to find an IQ, so how can you find an IQ? There is a one formula I have already taught you, that is IQ is nothing but it is intelligence quotient. It is intelligence quotient. Yes or no? It is intelligence quotient. And what is the formula for this? We have mental age upon chronological age. Mental age upon chronological age multiplied by 100. So let's we differentiate what is mental age and chronological age. So for this clinical question, you very well know in the clinical question it has been already mentioned that mental age of 3 years has been given. So ultimately the opposite will become chronological age. So in this clinical question, mental age is equals to 3 years, whereas chronological age is equals to 9 years. So let's put this data into our formula. So what is the formula? Mental age upon chronological age multiplied by 100. Yes or no? So let's start. Mental age is 3. Yes or no? Chronological age is upon 9. 3 upon 9. Yes or no? Multiply by 100. So you very well know 3 3s are 9, and when we divide 100 by 3, which somewhat comes along with the 33.3. So let's take a round figure of 33. Let's take a round figure of 33. Yes or no? So we very well know we have already made a table. Let's go to the table again. I have drawn for you guys over here. Mild, moderate, severe or profound. In what state 33 under comes? 33 comes under what particular part? Severe. Can you see over here? It comes under severe intellectual disability is there. So in this clinical question, your answer, without going into any another option, you have to select it is a severe intellectual disability. Again, I'm going to repeat this question. A 9-year-old child has a mental age of 3 years, was found from an IQ test. So if you want to look to the IQ's formula is mental age upon chronological age multiplied by 100. So if it is mental age is 3 by 9 into 100. So it is almost comes 100 by 33, which we have commonly taken as 33. Yes or no? And it undercomes a section of severe intellectual disability. So here your answer will become severe intellectual disability without going into any another option. So your answer should not get wrong out of this. Now come to this next MCQ. The next MCQ, what does next MCQ states that a person experience an intense fear. A person experience an intense fear of tall building and high places. Which of the following terms is used to describe? Now you very well know some patient do have a specific, some people okay, let me use one other color which is more probably visible. So patient do have a specific fear with specific situation. There is a specific fear with along with a specific situation. So we have termed different types of fear according to different situation. You very well know the most common what you know is claustrophobia. Yes or no? So what is claustrophobia? Claustrophobia is a person having a fear when he or she is in a closed space. That is called to be a claustrophobia. Yes or no? What is allurophobia? When a patient is having a fear with cat, it is called to be allurophobia. When a person is having a fear which is called to be a cynophobia, when we called a person is having a cynophobia, when what is cyno is nothing but it is dog. Some people are dog lovers, maybe some having fear of dogs, that is called to be cynophobia. Yes or no? But which is most important for me, what I want to ask is thanatophobia. What is thanatophobia? When a person is having fear of death, that is called to be thanatophobia. Very well. What is thanatology? Study of that is called to be thanatology, which you may have studied in FMT. The first definition, without saying it goes in the first definition, is thanatophobia. I mean thanatology, that is study of death. Related to that, that is thanatology. And if a patient is having fear of death, that we call it as thanatophobia. And what is been said, we can call it as algophobia. What is algophobia? Algophobia when a patient or when a person is having fear of pain, that is called to be algophobia. So when a patient is having intense fear of tall building, when a patient is having fear of tall buildings, or instead of tall buildings, I am using a word height. I am using a word height. Then it is called to be acrophobia. Then we call it as what, beta? Acrophobia. Yes or no? So can you see, look to the options? What are the options given? Acrophobia, algophobia, agoraphobia, and acrophobia. So don't be in hurry in answering the question. Look to the option. Algo is pain. That goes without saying. So here algo is not the answer. If it is agoraphobia, what is agoraphobia? Anyone? What is agoraphobia? What is agoraphobia? When it is marked anxiety from two or more situations. So the answer currently, it is not an agoraphobia. You may in a hurry take A option, but look to the spelling. It is acrophobia. Acrophobia. But answer is acrophobia. Your answer will be here option D. Again and again I am repeating, read the question carefully, read the options carefully, and then only you go to select the answer. Easiest questions are there. No questions will be very difficult in psychiatric points of view, but just don't be in a hurry. Don't lose your marks. Now coming to the next question. A 16-year-old girl has intense food cravings. Nothing but the question, reading to this line, you can easily feel that question is going with case of bulimia nervosa, 16-year or maybe anorexia nervosa, but let me still read the question. If a 16-year-old girl with intense food cravings, after eating her food in one go, she induces forceful vomiting. Her BMI is 27 per meter square. What is the likely diagnosis? So looking at the clinical question, it is going along with eating disorder. It is going with sort of eating disorder. So you very well know we have differentiated eating disorder into three groups. There we talk about three disorders. First one is anorexia nervosa. We go with anorexia nervosa. Second one is bulimia nervosa. Yes or no? And the third one is mixed or binge eating disorder. Binge or mixed eating disorder. So rather than for your simple understanding, there is also further difference in psychiatric textbooks, but let me keep it very simple for you. Let it be binge eating disorder. And you very well know there is one more option out of these three disorder, which is the most commonly seen is, don't get it as anorexia nervosa or bulimia nervosa. The most common is seen in day-to-day life, in day-to-day practice is binge eating disorder. So look to the question. A 16-year-old girl has intense food craving. After eating her food in one go, she induces forceful vomiting. Her BMI is 27 kg per meter square. So over here, if I want to differentiate anorexia nervosa, the body mass index will be less than 18.5 kg per meter square. Yes or no? And if I want to talk about bulimia nervosa, you very well know the BMI will be more than 18.5 kg per meter square. Yes or no? Okay, a 16-year-old girl with intense food craving. What will your answer over here? Anorexia nervosa or bulimia nervosa? See, looking to the clinical question, the person will be having bulimia nervosa because anorexia nervosa have further characteristics. What are the characteristics of anorexia nervosa? First one, patient will be having restriction of energy intake. Patient will be restricting herself by taking any energy intake. Restriction of energy intake. What is the second one? Patient will be having excessive fear of fattiness or excessive fear of fatness. Patient may having a image. What sort of image? Disturbance of body image. But recently there was the fourth characteristic which has been removed by the psychiatric association. You cannot differentiate, or you can the characteristic which has been removed by the of anorexia nervosa is nowadays, which has been not associated or we do not consider it, it is amenorrhea. Amenorrhea is a condition which we are not looking up to nowadays for diagnosing a patient as anorexia nervosa. If we talk about bulimia nervosa, what are the characteristics of bulimia nervosa? There will be episode of binge eating. Yes or no? Episode of binge eating will be there. Episode of binge eating will be there, or patient may show any compensatory behavior. You may have a question, what about compensatory behavior? Compensatory behavior like purging. What is purging? Purging is nothing but it is self-induced vomiting. What is purging, beta? Purging is nothing but it is self-induced vomiting. It is self-induced vomiting. Yes or no? So no doubt about it, this clinical question undergoes same way as bulimia nervosa, not as anorexia nervosa. Of course, it is not obsessive compulsive disorder. What is OCD, beta? OCD is when a person is having sort of obsession. You may have a question, what is obsession? Obsession is when something, some thoughts which are running again and again in the mind. And what is compulsion? When a person is having any sort of activity, whatever the thought coming in the mind, and then when a patient is doing that particular activity at that particular moment, we call it as compulsion. Yes or no? So of course, obsession compulsion is not the option over here right now. It is bulimia nervosa. Am I clear with this thing? Okay. Now, that is not a single exam which do not have any question about alcohol. Yes, there is no such exam without any alcohol withdrawal question. Exam is incomplete. So when exam gets complete, when there is a question of alcohol related any sort of thing, either is Wernicke's encephalopathy, Korsakoff, alcohol withdrawal syndrome, or delirium tremens, or any sort of question will be there 110% in terms of alcohol related topic. So what is the question right now? What is the earliest symptom of alcohol withdrawal? So So now, without going, some students will go and take delirium tremens. But again, I'm saying, read the question carefully and then only take your answer. What is the question? What is the earliest symptom? The earliest symptom what a person will have is tremors. Without it goes without saying that patient will be having tremors at the earliest most symptoms. Tremors will be seen between beta 6 to 8 hours of withdrawal of alcohol. 6 to 8 hours of withdrawal of alcohol, yes or no? And delirium tremens we can see around 72 hours. Yes, we may seizures about 36 hours hallucination along with that particular part. But if I want to, there is one more MCQ which can pop up on your screen while giving your exam. That what is the peak time? What is the peak time for delirium tremens? So the question what I want to say is, at what particular time peak we can see a delirium tremens? So peak time for delirium tremens means we can see an episode of delirium tremens in between of 48 to 72 hours. So, or basically we can say in between 2 to 3 days. If for single figure, if they are asking about single figure, 72 hours or 3 days. If they are asking about peak interval, if they are asking, your answer will be between 48 to 72 hours. Am I clear with this thing? So, if they are asking earliest symptoms, it has to be an alcohol withdrawal. It has to be an alcohol withdrawal. Earliest symptom, tremors. If they're asking specific characteristic, it has to be delirium tremens that goes around abrupt withdrawal of alcohol after 72 hours or peak time between 48 to 72 hours. Okay, coming to the next MCQ. Okay, your favorite question, schizophrenia question, I mean psychiatric MCQs will be incomplete about schizophrenia. You may have any sort of thing that yes, schizophrenia is all about, psychiatric is all about schizophrenia. No, psychiatry is not only about schizophrenia, there are much more disorder, but yes, schizophrenia is an integral part of psychiatry. So negative symptoms of schizophrenia. How many negative symptoms of schizophrenia are there? Anyone? Negative symptoms of schizophrenia. Negative symptoms of schizophrenia. Anyone? So there are basically we have differentiated schizophrenic symptoms into two. That is, we can have positive symptoms and we can have negative symptoms. So there are two types of positive symptoms. What we know, first one is delusions and second one is hallucinations. Yes or no? First one is delusion and second one is hallucination. What are the negative symptoms? What we know, there are 5 negative symptoms. First one is anhedonia. The first one is anhedonia. What is anhedonia? Loss of pleasure, loss of interest in pleasurable activity. When a person is having sort of interest or getting pleasure from certain activity, but now patient has abstains from it, that patient is not enjoying that particular activity. Then the second negative symptoms is evaluation. What is evaluation? Loss of will or loss of drive. Then the third one is affect flattening, where whatever anything goes, any episode takes place but patient will be not having any sort of change in the emotions, that is called to be affect flattening. And then is asociality is one of our major symptom or major negative symptom of this particular schizophrenia, asociality. Yes or no? Asociality. Okay, so asociality is one of the negative symptoms of schizophrenia. And the third and the fifth one, last one, that is alogia. What is alogia? Patient will be engaged in little conversation or very less conversation, or maybe mutism will be there. We have termed it as alogia. Okay, so look to the particular options given over here. First one is evaluation, alogia, anhedonia, and anomia. Is evaluation present? Yes, so it is a negative symptom. It is alogia present? Yes, alogia is present. Yes or no? Is anhedonia present as a negative symptom? Yes, anhedonia is present. Anomia is present? No, we have not read about any sort of terms in anomia and negative symptoms of schizophrenia. What we have heard is alogia. So anomia is not a negative symptom. So anomia is not a negative symptom. Yes or no, anomia is not a negative symptom. Okay, so moving to the next question, beta. Okay, a 50-year-old man has a fight with his neighbor. Now, patient have already fought with his neighbor. Next day, feel that neighbors are following him and recording his movement. And he fears that they are planning to kill him. What does his symptom represent? So out of this clinical question, there can be two answers applicable over here. Yes or no? Why? So this is all about delusion. What is delusion? First, let me discuss about delusions, and then we'll talk about different types of delusion for particular moment. So what is delusion, beta? Delusion is nothing but it is false, fixed, or firm idea or belief what a patient have, although their friends, relatives and family have already explained, but they are not going to get convinced. So there is a false fixed firm idea which is present in their head. They are not going to convinced by anyone. Yes or no? So there are various types of delusion. We very well know delusion of preference, delusion of persecution. Yes or no? Then delusion of nihilism. We have discussed about Cotard syndrome. Yes or no? Delusion of love. Yes or no? So let's talk about this particular moment. What is so? Of course, no thought insertion is present over here. Thought insertion when person has been given a thought, any particular mind has been inserted. Yes or no? Externally, that is called to be thought insertion. So here it is not a thought insertion. No, none of the person have said to that particular person that his neighbor has been referring to you, or neighbor is recording his movements, following him, planning to kill him. No. So that is not a thought insertion, of course. Delusion of control, no one has been controlled. Yes or no? Either there can be two options over here: delusion of persecution and delusion of reference. So let me talk about delusion of persecution and delusion of reference. So let me talk about delusion of persecution first. What is delusion of persecution? When patient feels that, or patient believes that someone is trying to kill him or her. When patient believes that someone is trying to kill him or her, that is called to be delusion of persecution. Now, if I talk about delusion of reference, what is delusion of reference? Patient believes that people are talking about me, or patient believes that someone is spying on me. Yes or no? So look to the question. Both the symptoms are given, that neighbors are following him, recording his movement, that sort goes in the favor of spying on me, or yes or no. And the second is they are planning to kill him. So of course persecution is be there and reference point of view is there, but more probably whenever in this sort of question is been given, go for persecution, because the moreover classical point is given, someone is trying to kill, is planning to kill him, and that ultimately concludes of that they're recording his movement and following kind of reference. So I want you to take this answer as delusion of persecution. Don't get confused. This type of question will be there in the exam where you will get confused. Should I take persecution or should I take reference? But if they are given in the clinical question that they are planning to kill him, go away, close your eyes, straight away, go for persecution. Don't get trapped in examiner's words. I always state in my lectures, examiners play with words. Don't get trapped in the words of examiner. Here your answer is delusion of persecution. Here your answer is delusion of persecution. Am I clear with this thing? Should I move to the next question? Okay, so looking to the next question, 14th one. Now the question states it is going along with the terms of sexual dysfunction, or rather than I using a word, sexual disorder question will be there. Yes or no? So in this clinical question, what is the question is been given? The most common cause of erectile dysfunction. The most common cause of erectile dysfunction is diabetes mellitus, vasculogenic, psychogenic, or hypothyroidism. 110 times I have repeated in my lectures as well. The most common cause of erectile dysfunction is psychogenic. The most common cause of erectile dysfunction in the middle-aged man is psychogenic. That goes without any saying. Hypothyroidism, why not? Because we very well know hypothyroidism is more commonly associated with females. Thyroid issues are more commonly associated with females. Yes or no? Vasculogenic can be there, but it is kind of an organic cause. Yes or no? But if we compare organic cause and psychogenic cause, the most common cause what we find in day-to-day life for erectile dysfunction is vasculogenic. There is no such relation of diabetes mellitus with erectile dysfunction, maybe in a later stage where medicines cannot work, where poor immunogenic effects are seen with diabetes mellitus, but there is no such correlation with erectile dysfunction and diabetes mellitus. So out of nowhere, there can be two answers in this. I'm not saying no, that can be vasculogenic and psychogenic are the cause of erectile dysfunction. But if they are asking most common cause will be most common cause will be psychogenic. Am I clear with this thing? Okay. So 15th question. Now coming to the next question. Fear of situation where patient is being concerned about harshly judged by his or her performance. So patient is having fear of situation and patient is concerned highly or harshly judged by mean patient is having difficulty with how society will judge me. Yes or no? So this is without saying it, of course goes for what? Social anxiety disorder. So sir, how can you differentiate about panic disorder, generalized anxiety disorder, or maybe selective mutism? Let's differentiate any sort of these points. You very well know panic disorder, patient will be getting panic attacks. Patient will be having a fear of dying. Patient will be having what, beta? Fear of dying. Yes or no? We call it as fear of doom. Yes or no? Fear of doom. Then, what is generalized anxiety disorder? If I am talking about generalized anxiety disorder, that clearly indicate more commonly seen in female, and in generalized anxiety disorder, patient is always anxious about small things. That is called to be generalized anxiety disorder. Selective mutism, no. What is selective mutism? Patient stops very selectively, means it commonly talks with such people in which we call it as introvert people. Yes or no? Selective mutism, where they are very selectively talk with the people, that is called be selective mutism. So looking to the clinical question, your answer has to be social anxiety disorder. Okay. Now, this is one of the repeatedly asked question along with another clinical question. The most common psychiatric disorder in the world. Is it eating disorder, or is it an anxiety disorder, or it is bipolar disorder, or it is a depression? The most common psychiatric disorder in the world is depression. You very know what are the symptoms of depression? Anyone? Depression is also called to be major depressive disorder. Yes or no? It is also called to be major depressive disorder or unipolar depression. Yes or no? So what are the characteristics of depression? Depression is more commonly seen with female more than male. If we talk about in terms of ratio, it is seen in raised to 2 raised to 1. Yes or no? What is the mean age? What is the mean age of onset of depression? Mean age of onset of depression is 40 years. So instead of 40 years, I am going to write, as it is more commonly seen in females, I am going to write it is more common. It is more common in middle age females. It is more commonly seen in middle age females. Yes or no? What are the neurotransmitters which are associated in depression? That is serotonin. Then second is norepinephrine, and third one is dopamine. You very well know that serotonin, norepinephrine, dopamine, every the every neurotransmitter in depression decreases. So ultimately, what drugs we give? We give SSRI, yes or no? I have given one question about SSRI. The next question is almost related to depression. Which SSRI is contraindicated in pregnancy due to teratogenic effect to the fetus? So looking to the particular question, I want to talk about antidepressant drugs. So in antidepressant drugs, you very well know what sort of depression, what sort of drugs do we give? We can give SSRI, we can give NDRIs, nor epinephrine dopamine reuptake inhibitors, yes or no? Then we can give SNRI, yes or no? Serotonin norepinephrine reuptake inhibitor group we can give. We can give TCA, that is tricyclic antidepressant. We can give MAO inhibitors, and the last group we have a SARI. So as we call it, SARI, SNARI, NARI. Yes or no? That is SARI, SNRI, NDRI, and SSRI. So most commonly, the drug of choice for antidepressant will be SSRI. So I can expect a question from SSRI very majorly rather than other groups. If I want to talk about TCA, we have only one option. What we need to remember for particular exam, that what is an antidote for TCA toxicity? What is an antidote of TCA toxicity? It is sodium bicarbonate. This is one of a option MCQ which you may expect, which can come in our exam, that what is an antidote for TCA toxicity? It is sodium bicarb. Yes or no? And you very well know, pharma faculty would have been taken this point about MAO inhibitors, that is along of cheese reaction. This is the second MCQ which will come in pharma point of view. These are the two options. And the third one what I want to take is all about SSRI. What sort of SSRI we have? Can you name these SSRIs? We have sertraline, name is being given sertraline, fluoxetine, paroxetine, escitalopram, yes or no? So for SSRI, what I want to talk to you about certain characteristics of SSRI, that what is an onset of action when you start a patient on? When you start a patient on SSRI, what is an onset of duration? Onset of duration is between 3 to 4 weeks. It is between 3 to 4 weeks. If we talk about what is the most common side effect, don't say it is NVD. NVD is the most common all the drugs, but other than that, that is constipation, vivid tremors, and dry mouth. Vivid tremors and dry mouth. But what I'm more interested in, which is a long term sexual dysfunction. So long-term sexual dysfunction is libido. That is loss of sexual desire. And the second one is delayed ejaculation. So when you are prescribing any patient of depression for SSRI, if it is a male, and if you are giving SSRI, one of a major symptom, long-term sexual dysfunction, is delayed ejaculation. So when a person is suffering from delayed ejaculation, can you give this SSRI? Sorry, when a person is suffering from premature ejaculation, can you give SSRI? Yes. So beta, this is one of a question which can pop up on your screen while giving exam, that what drug do we give for premature ejaculation? So for premature ejaculation, we use SSRI. Not SSRI, basically not SSRI, but what we are using in simplest manner, if I want to say, we are using side effect of SSRI. What is the side effect of SSRI? It is delayed ejaculation. So when a patient is suffering from premature ejaculation, we are giving what? SSRI, that's delayed ejaculation. But coming to the clinical question, let's talk about the clinical question. Which SSRI is contraindicated in pregnancy? So always remember that paroxetine, what I always used to say in my lecture, that P for P. What is P for over here? P for over here is for P for pregnancy, and P for paroxetine. It is for paroxetine. Paroxetine is contraindicated in pregnancy because it causes what beta? It causes cardiovascular defect in the fetus. Cardiovascular defect in the fetus. That's the reason we do not give or do not prescribe paroxetine in pregnancy. Am I clear with this thing? So which SSRI is contraindicated in pregnancy due to teratogenic effect to the fetus? That is paroxetine. Come to the next question. Oh, great question. Easiest specific question. CAM test. What is CAM test? Beta, confusion assessment. Confusion assessment method is used in the diagnosis of dementia, schizophrenia, delirium. Anyone? The question simply goes in favor of delirium. There is only specific test. We have already talked about delirium. That is specific test. Specific test for delirium. For delirium is CAM test. That is confusion assessment method. That is confusion assessment method. When what we see on EEG, we have seen diffuse. What is EEG, beta? Electric encephalogram. Yes or no? That majorly records the activity of the brain activity. Yes or no? When we look for the EEG, that shows a diffuse slowing of cortical background activity. It is showing what? Cortical background activity. It shows what? Cortical background activity. Yes or no? But there is always one exception. Medical field is all about exceptions. So which is the exception in which there is fastening of cortical background activity? Anyone? What is the exception in this? In every disorder what we have in our course for exam, it always shows diffuse slowing of cortical background activity. Either it is delirium or something like that. But there is one exception in which there is a fastening of activity. That is exception is alcohol withdrawal. Alcohol withdrawal activity will be having what, beta? Fast activity. So CAM is used in diagnosis of delirium. What is delirium? Delirium is nothing but we call it as what, beta? Acute confusional state. We call it as what? Acute confusional state. And why it is acute? Because the onset will be between hours or few days. And it have a what type of course? It have a fluctuating course. It has what course? Fluctuating course. Yes or no? So that's what delirium is. So confusion assessment method is used in diagnosis of delirium. CAM test is used for diagnosis of delirium. This is a specific test to diagnose what? Delirium. To diagnose what? Delirium. I hope I am very clear with this thing. Coming to the last second question for us, neologism. So neologism is a disorder of thought of content, thought form, thought stream, or thought possession. So you very well know we have come to the mental status examination. How we examine the patient of psychiatric patient. How do we exam? That is mental status examination. So for mental status examination, we have very well known 9 points. Sorry, not 9 months. We have 9 points are there. What we discuss? Yes or no? The first one is general build and appearance. Yes or no? General build and appearance. And that what is the second point what we discussed? The second point what we discuss is, anyone? Is speech. What the second point what we discuss is speech. Then the third point what we discuss is mood and affect. Well, that is mood and affect. Yes or no? And the fourth point that we talked about is thought. The major point I have already stated in my lectures that the question what you can expect in our exam is from thought. I have asked to draw specific chart for the thought and I have redone in class in regular lectures. And again, I'm going to do today for you guys so that you will get a quick revision of thought. Yes or no? Thought part. So if we are talking about thought, so thought has been further differentiated to how many parts? Thought has been further differentiated to 4 parts. The first one we called it as what, beta? Flow or stream. We have flow or stream. And second point we have content. Third point we have form, and fourth one we have possession. Okay, so flow, stream, content, form, or it may be possession. Yes or no? So if I'm writing over here for okay, flow, stream, content, flow, stream, content. It is content. If you are not visible, it is not. If it is not visible to you, it is content. Okay, either it is flow stream, content, form, or it may be possession. So I'm writing here for you that what does comes in flow or stream. So you very well know I'm just drawing a chart in flow or stream. Either there can be two things, either there can be speed or it can be continuity. If it is speed, speed can either increase or speed can either decrease. If speed can increase, there can be 2 points, that is flight of ideas, or it can be proximity. What is flight of ideas? Thoughts are flowing very rapidly again and again, one by one, one by one. What is proximity? Proximity is nothing but it is ordered flight of ideas. So if I talk about proximity, if I'm saying ordered flight of ideas, that means goal will be reached. But if I'm talking about flight of ideas, thoughts are following rapidly each other, goal will not be reached. That's the only difference between flight of ideas and proximity. If speed decreases, there will be retardation of thinking. There can be rot. What is rot? That is retardation of thinking, and there can be circumstantiality. There can be circumstantiality. Yes or no? Now, if I talk about continuity, in continuity there can be two things. Either there can be perseveration. So what is perseveration? Thought persists beyond the point of relevance. Thought persists beyond the point of relevance. Thought persists beyond the point of relevance means whenever I'm asking question, what is your name? Mukesh. What do you do? Mukesh. Where do you live? Mukesh. What do you study? Mukesh. What subject you are doing? Mukesh. So the point, what has been present, is been stuck in the mind. So, but that is called perseveration. Then second one is, if I talk about, that is thought block. In continuity, the second point is thought block. So this is flow or stream. Okay. Now what is the second thing we talk about? Content. In content, we have already talked about delusion, if you remember. Yes or the delusion of persecution, kind of. Persecution, reference, erotomania, delusion of love. That comes in particular moment of content. Now, if we talk about form, yes or no? Form have a or thoughts organization. What patient is having formal thought disorder present or not? So if I talk about form patient, we talk about formal thought disorder. Informal thought disorder, which is more commonly associated with schizophrenia. It is more commonly associated with schizophrenia. Yes or no? So formal thought disorder. So in this we have 5 points. Loosening of association. Second one is derailment. Loosening of association. Second one is derailment. Third one is tangentiality. We have already discussed this in very detail. Tangentiality. Fourth point is neologism. So here your option comes that neologism undergoes what part? It undergoes form. So coming to this part, neologism is a disorder of a form, thought form. Am I clear with this thing? And let's discuss fifth point also, so that you may remember for your exams. And the fifth point, what we have is talking past the point, forbidden. Talking past the point, or we may call it as forbidden. And the fourth point, what I was showing you about possession. So in possession, you very well know we have obsession and compulsion. That's what we have in MSc mental status examination. And last but not the least, the exam is incomplete without lithium. So what is lithium? Lithium usage in pregnancy can lead to which of the following teratogenic effects? Lithium usage in pregnancy can lead to which of the following teratogenic effect? It is cardiac, facial, it is not CNS, it is CNS defect, or urogenital effect. You very well know lithium toxicity can cause cardiac defect, and we call it as what? Abstinence anomaly. We can get what? Abstinence anomaly. So lithium is being not prescribed for not used in pregnancy because it can cause teratogenic effect. Lithium you very well know. Lithium is a mood stabilizing agent. We do give sometimes in depressive disorder. Mood stabilizing. It is a mood stabilizing drug. Yes or no? So here we have completed our session for this. So wishing you, these are the most 20 expected question, out of which these are the most 20 expected topics, out of which most of the question will be from this MCQs only. So wishing you all the very best for the exams. Read the question carefully. Do not be in a hurry. Use your time properly. Be confident during exam. There will be some MCQ which will be out of our range, which we may not know the answer, or which we may not heard about it. Just take the answer what your heart says. Am I clear with this thing? So till the time, all the very best. Looking forward. Wishing